Good morning, everybody, and welcome to the Wayne State University School of Medicine Department of Pediatrics Pediatric Update. I'm very pleased to present this morning our speaker, Dr. Shantalea Johns. Dr. Johns is a clinical social worker licensed in Michigan, Ohio, and Washington. She's a certified cognitive-based therapy and has extensive education in trauma-informed care. In addition, Dr. Johns is the Director of Continuing Education and an Assistant Professor at the Wayne State University School of Social Work. She leads the development and administration of continuing education credits for social workers and allied health professionals. Dr. Johns' research primarily focuses on understanding the neurobiology of trauma and the social determinants of poor mental health and substance use among African American youth and from adolescence to early adulthood. In addition to this work, Dr. Johns studies the use of risk reduction interventions in educational settings and conducts workshops and seminars to provide strategies to engage better those affected by trauma. Today's title is Neurobiology of Trauma and Trauma Recovery in Adolescence and Early Adulthood. Please join me in welcoming Dr. Shantalea Johns.
Thank you so much for the introduction and just the opportunity to be able to spend my Wednesday morning and your Wednesday morning together with me. As I was thinking about this presentation, as I often sort of reflect on life and just how, things sort of come together when I'm asked to do a presentation, especially when it's on the topic of trauma, because it's something that's very personal to me. And when I thought about this training, I thought back to the many physicians over at the DMC who really offered me support as a young girl trying to figure out life in the midst of a traumatic environment. So this brings me great pleasure to be able to talk with you all about trauma and ways in which you can support your patients who you may believe is showing signs and symptoms of mental health distress, or they disclose to you that they have experienced a trauma. So I'm going to go ahead and share my screen and we're going to get going. And of course, it always takes a few minutes. I'm assuming you all can see my screen. If I can just get a confirmation of that.
Yes.
Yes.
Thank you so much. So here's our learning objectives. I'm going to talk about the neurobiology of trauma, assess some of the mental health symptoms from a trauma-informed perspective, and talk to you about how we determine the impact of trauma and diagnosis and symptoms on the clients that we serve, who maybe have disclosed to us or their parents have disclosed to us that they've experienced a traumatic event. Then I'm going to talk to you a little bit about trauma-informed therapy, trauma therapies, and include some information about how we provide education to our clients or their loved ones about symptoms and treatment. So here's just some of the questions that we will answer throughout our presentation. So what makes something traumatic? Who has trauma? What does it mean for therapy to be trauma informed? How do mental health professionals treat trauma? What does a trauma informed assessment look like? And then what can you do? I always like to give a little disclaimer because a lot of the material that I'm going to include in this course includes some interventions and some modalities that are beyond some folks' authorized practice or areas in which they're competent in. So as a licensed professional, I always just want to encourage folks that review the material through your lens of practice and keep in mind any legal or ethical codes that will bound what you're able to do with someone who is in your care and seeking support. So essentially, I'll introduce you to some approaches, but again, that will be up to your scope of practice and your area of expertise in terms of determining what is best for you to use in your practice. So what is trauma? I always start off, even when I'm talking to parents, I do a lot of trainings with actually two nonprofits in Detroit, youth serving organizations. So I'm always asked to do trauma trainings for the parents. So it's always been important to me that we understand what it is. I know there's lots of talk about trauma more recently, but you'll be surprised at just how many parents and how many loved ones maybe know that their child is showing signs of a change, but can't quite determine what it is. So being able to just give them that foundation always helps. So according to SAMHSA, trauma is a negative life event or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening and has a lasting adverse effect on the individual's functioning and their physical, social, emotional, and spiritual well-being. So we know that not all events are stressful, and that's why even the DSM defines trauma as being an event that actually has someone to perceive themselves as being in a threat or some kind of serious injury has occurred to them or sexual violence. So although the DSM sort of narrows it down to actual and threatening events of death, sexual trauma, or injury, we know that some events for our young people are very stressful. And some of those psychosocial stressors happen over time to our young person. And so you can see these very same symptoms in your young person, even if they don't quite fit the definition of it being a traumatic event, such as bullying, the divorce of parents. I recently had a young person who talked about losing their animal was very stressful, and they used the word trauma, and it was traumatic to them. So I always give the definition, but I like to include the fact that everyone has a story and they see the world through their own eyes. And even when our young people experience things, even as the loss of a pet, it can be very traumatic to them, and they can own that for their story. So we have the definition from SAMHSA, we have the criteria in DSM, but it's just my practice in the work that I do that if a young person tells me that something was very stressful to them, and maybe you start to see that they're showing signs of hypervigilance or a state of shock or just sad and crying, then we let them call that trauma. We let them own that story. And that's very important when we are meeting clients where they are. And we also know that culture plays a role in how someone experiences life and how they perceive something to be traumatic as well. So it's just a lot of nuances that I will remind you all throughout the session. because we have this language, but there's just still so much that we're learning about someone's life experience and how they show up in life and what they perceive as being traumatic for them. So our instinct to survive defines our reaction to trauma, regardless of our conscious awareness of it. So we all have this need to survive. And when someone or a young person experiences a traumatic event and they feel that they're unsafe, again, letting that be very broadly, depending on the young person's story, they may show reactions regardless of if they're even aware of it. And I've had clients in practice that they will describe hypervigilance, they would describe low mood, they will describe being easily startled. Some of their parents might talk about the child going back to wetting their bed. And they may not even know that that's something that could be connected to what has happened to them. But again, I like this quote because it just really hones into the fact that we're all designed, our brains and our bodies are designed to keep us safe. So whenever our brains and our bodies don't feel safe, we'll have a trauma response, even if we're not consciously aware of it. There's also information that tells us that when someone experiences an event, it becomes traumatic to them based on their perception of the event. So I may look at one situation that happened in my life and able to make sense of it and move on. But someone else, even a colleague of mine, may see that same situation and their perception of it be completely different. And their response, their physical and their mental response can be completely different as well. So again, this idea of letting someone own their story and letting them lead the conversation in terms of what they have experienced and how it has impacted their life. We also think about our perception of the event after it has occurred as well. So someone can experience an event, several weeks can go by, and they sit and they process, and then they realize, I could have died. I was pretty unsafe in that situation. And so even the aftermath, thinking and processing about the event, weeks, months, or even years later, could develop a response in your clients or even yourself. Because I like to make my sessions very personal, because I know that we all as professionals don't live in a box. So these things can happen to us as well. So keeping in mind and just being cognitive that your young person could have experienced something several years ago, but processing it and maybe talking to their friends about it, and their friend may have had a very similar situation, and that sort of triggers them. And now their perception of the event is different, and now they're starting to have a response. What's important here is that we offer support. So whether or not the event happened yesterday, several weeks ago, in 2020, we're willing to be curious and ask questions when we notice that our adolescent or a child that we're working with shows some signs of a decline in their mental health. So we know that, again, thinking about this idea that our bodies and our brains are designed to keep us safe. We also know that we see the world through our senses. There is so much information that we take in throughout our day, even if it's just early in the morning. There's so many things that we have taken in our world around us. So it's important to be able to sort of think about, how we think and how we take in information. And so with so many things going on around us, it would be nearly impossible for our brain to sort of take in every smell, every taste, every touch. So through neuroscience, we understand that our brain sort of goes through a process of filtering information, selecting certain parts that we need to hold on to. And even in discussions like this with some of the parents that I work with, helping them understand that events in our life are filtered through our brain, filtered through our past experiences, helps them understand that their child may be showing signs that something is there. And some of the environments that they're in may also be triggering to them. Because we know that when we think about information entering our brain, we know that it's filtered through either our thinking brain, part of our brain, or the reactive part of our brain. And so when you're explaining this to parents, helping them understand that our first reaction is to react, because again, our bodies are designed to keep us safe. And once a child is able to really process, if they can, depending on their developmental level, they're able to shift information over to the thinking part of their brain. Perhaps they can make more sense of what has taken place. So again, I like to offer this information to parents as well, because it gives them hope, helps them understand what their child is experiencing. And when I first started doing work with parents, the idea of talking about the brain and thinking that I was going to talk over what they were saying turned out to be wrong, because parents wanted to know more about what their child was experiencing. So giving them that psychoeducation, helping them understand that we feel, we assign meaning, and then we act, and those behaviors begin to show up, gave them a deep breath, realizing, okay, so it's not my child, but it's the situations that have taken place that is causing what I'm seeing in my child, or what the teacher is reporting to them. So I always like to sort of give parents, as much as they can take in, some information like this, and even show this chart, because I like for them to understand that when your child doesn't have time to think, or they're faced with a threat, their brain shifts the information over, and now you may see the racing heartbeat, the digestive problems, the sweating palms, the fight, flight, or freeze response, or fawn, which we're going to talk about later today. So giving parents this information, even if it's in short bites, actually liberates them, because now they understand that, okay, my child's body is doing what it's supposed to do. It's the actual event that is abnormal. And so here's just some other brain development charts that I like to show. And it's centered around some of those key developmental tasks. So some of those things that we all look for in practice when we're working with a young person. And then what happens or could happen when a child has experienced a traumatic event. So this one is from 0 to 5, and it just talks about some of those key developmental tasks being they're able to recognize and respond to emotional cues. They show attachment to their primary caregiver. There's some development of visual or auditory perceptions. And of course, this isn't an all-inclusive list, but I'm just trying to show you what happens and how I talk to some of my parents about some of these key developmental tasks, and then what may be taking place in their young person who has experienced a traumatic event. So we have some of these key developmental tasks, and then for a child between the ages of 0 and 5 who has experienced a traumatic event, some of the trauma responses may be sensitive to noise, avoidance of contact, heightened startle response, fear of being separated from someone that they love or a place that they feel safe, and unsure whether or not they should trust someone else that is around, or have a heightened sense of wanting to seek protection. Some developmental tasks in school-age children, so around 6 to 12, some key developmental tasks they should be able to, and again, this is broadly speaking, manage fears, anxieties, and aggressions, sustain attention for learning and problem solving, and control impulses and manage physical responses. Now, when trauma enters the picture, we may see some of these things: mood swings, learning problems, social anxiety and fears to danger, attention seeking, reversing to younger behaviors. And again, that unsure what's dangerous and where to seek protection. Now, some of our parents or some of our young people, again, may not, I have lots of examples I can share of families who don't say the word trauma at all, but they may talk about that their school-age child is experiencing learning problems, have attention-seeking behaviors. They may talk about wetting the bed, or they're picking up some of their behaviors that they had when they were a little younger. So again, they may not be using the term, and some of these experiences may not be the result of a trauma. What I'm encouraging you all to do is just be curious. So even if the parents may say, a child's having problems in school, the teacher calls me every day, the social worker has me up to the school, be curious about that. And it's not all because of the child being a child. Something could very well have happened in the child's life that is impacting their ability to show up in the way that they should be showing up given their age range. So just being curious and asking those questions. And so here's just another slide in terms of brain development in school age children. And I put children up to 21. Some of the key developmental tasks: thinking abstractly, anticipating and considering the consequences of their behavior, accurately judging danger and safety, being able to modify and control their behavior to meet some or all of their goals. When trauma enters the picture, you may hear the young person describing, or the parent describing, that the child is showing inappropriate aggression. Or they may say, again, someone at the school or the after school program is calling them to the school, having them come up there because of there's some aggression that the child may be exhibiting. The young person, when you're asking questions about their future, they may not be able to talk to you about that. They may not have even thought about what is possible for their life, or even started planning for that. Now, again, the goal here is just for us to ask questions, dive into what the child or what the parent is saying, because some of these things are just typical adolescent or typical child behavior. Some of it is a result of trauma, but we wouldn't know unless we ask those questions. I want to take a few moments, and hopefully this is a reminder about ACEs and brain development and how important this is, especially for you all in your practice, understanding how trauma impacts the brain and how multiple levels of stress can have long-term effects on the clients that you serve. So let's see if this video will play, and then we'll come back.
Our brains develop and change throughout life, enabling us to learn and do new things, and to adapt at every age. But childhood, and early childhood in particular, is the most sensitive and critical period for brain development. As a child interacts with the world, their experiences, both positive and negative, stimulate the brain, causing it to form neural pathways that lay the foundation for lifelong cognitive and behavioral functioning.
I like to think of brain development as the brain is like the site of a town, so you can lay out road work. You're laying down roads, according to, in the brain's case, according to experiences. So you have an experience and your brain lays down a path. And the more you have that experience, the bigger the path is going to get and the stronger, and then it's paved and it becomes a real road and a highway. And you're laying out the grid work of the town according to your experiences. And that's very much like the brain development. The more you have experiences, the stronger those electrical circuits are going to be. And that's going to shape the way you think and act and view the world.
Safe, stable, nurturing relationships and environments provide the context for healthy brain development when children have ample opportunities to learn and explore. In this setting, children acquire a range of experiences that stimulate different parts of the brain, allowing for healthy, balanced development. Some degree of adversity and stress is a normal and essential part of human development that can help children learn how to react to future challenges. But a child who's repeatedly exposed to adversities like abuse, neglect, or unstable relationships and environments may experience what's known as toxic stress, and this can disrupt brain development.
Our experiences literally shape the way our brain is developing in the brain architecture. So if you have a baby, a very young baby, who cries when they're hungry, and mother comes over and feeds the baby and helps the baby settle down, the baby goes back to sleep, that happens 5-10 times a day. And that is laid down, those electrical circuits are laid down in the brain. And so the baby learns that you cry, you get fed, you soothe, and you go to sleep. And that experience is sort of coded into the brain, just like any other experience. So good experiences help the brain develop in a certain way. And if you have adverse experiences, that same baby cries and cries and cries, and the parents are addicted to opiate drugs, let's say, and they ignore the baby. The baby's left alone for 10 hours in the dark. That baby's brain is still developing, but it's developing in a different way. Their experience is much different. And so it is developing in a way that says you can cry and cry and cry and escalate that stress response as much as you want, nothing's going to happen. And the interpretation of that is not only is the brain realizing that they're not going to get soothed, but the child learns, and this is laid down the brain, the child learns that the world is an unsafe place, that they are insignificant. There's no one out there to help them. And that is all laid down in the brain as well.
There are different forms of stress that any individual is exposed to. There's positive stress that oftentimes is very short term, but it's something that everybody experiences. So even if you said, waking up in the morning, going to work, going to school, that's, one form of stress, very short term, but something your body has to adjust to. You can have, very neutral forms of stress that are a little bit longer term, but things in which, there are resources and support that help you adapt to it, whereas there's other kinds of things that are more long-term kinds of negative stress, and that's where toxic stress really fits into. Things in which person doesn't have, or an individual does not have, the kind of resources and support to try to deal with it, and it has a negative effect in the long-term consequences on that particular individual. So it's toxic in the sense of the body responds to that stress. One of the things that is produced is a hormone called cortisol, and that constant production of cortisol has a negative effect on brain development, on neurological development, and on other kinds of organs and tissues in the body.
When we experience stress or encounter a threat, the brain triggers the body to produce hormones that activate a stress response, or what's often referred to as the fight or flight response. In a moment of crisis, this response is necessary and potentially life-saving. But stress can become toxic when the stress response system is activated frequently or for prolonged periods of time. If a child is constantly afraid, her body and brain will remain on high alert, preparing her to react should a threat return. Her body will continually produce stress hormones, and the stress response system will remain activated in her brain, drawing energy away from other neural pathways in need of development or maintenance. In a child experiencing toxic stress, parts of the brain that might be weakened are those regulating complex functions like emotional self-regulation, social interactions, and abstract thinking. This may have consequences throughout life and can result in social, behavioral, and cognitive challenges.
Toxic stress implies a certain level of adversity, and that often occurs early in life within childhood. So children who have experienced adverse childhood experiences have been found through very diligent research to be at increased risk for a number of long-term problems when they reach adolescence and adulthood. And these problems really span multiple domains. They can be behavioral problems, emotional problems, and physical problems. So if you think about it, children who have had early adversity are at higher risk, much higher risk for major depression and suicidality, for anger management problems, for delinquency and high-risk behavior, for dropping out of school, for teen pregnancy, for runaway behavior, for adult criminality, and for liver disease and lung disease and heart disease, among other things. So it has a profound long-term impact, potentially.
And yet, the brain is capable of healing and changing. Effective treatments can help those affected by early adversity and give them a chance to heal from traumas and learn new ways to interpret and react to stressors and other stimuli. Fortified by this information, we can shift the conversation away from one that blames and punishes people for inappropriate reactions and behaviors that developed in childhood due to adversity and trauma. Instead, we can champion the need for expanded services and opportunities that help people overcome early adversity. And we can focus on ways to prevent abuse, neglect, and other challenges before they occur.
I don't want to imply that any child who experiences early adversity is on a mission where they inevitably will experience these adverse effects long term. That's not the case at all. Many kids are resilient, and so they are able to overcome this adversity very early on and prevent the long-term effects. Some adults will experience those long-term effects, but there are ways that we can help the adults. And very often, I work at a child sexual abuse clinic, and very often our parents will come in, the mother will come in and say, my daughter was sexually abused, and it comes out while I'm talking to her that she was sexually abused as well. She never got therapy. So for 20 years she's been living with this experience and hasn't told anyone. That's not too late. She can still get help. She can still get therapy. She can still work through that. She can still kind of overcome that and move on and not have an increased risk of adversity. There are other social programs that are helpful. For example, programs that help people develop some of those skills that maybe they didn't develop early on. The skills are related to planning, controlling their emotions and controlling their impulses and getting hold of that automatic response, that jump to anger, getting hold of that, calming it down. Learning how to do that can help tremendously.
CDC is the nation's public health agency, and as such, we're really interested in those factors, risk factors and protective factors that influence health. And it turns out that early adversity in the form of violence and other adverse events has a profound impact on health throughout the lifetime. Mental health, impacting infectious diseases as well as chronic diseases. So as such, early adversity and the influence of that is critically important from a public health standpoint, and it's strategic. If we can reduce or eliminate early adversity, we can have an enormous impact on health of the U.S. population and, in fact, people around the world during the course of their entire lives.
In Lesson 2, you'll learn about the CDC Kaiser Permanente Adverse Childhood Experiences Study.
All right. The reason I like to show this video is because there's a thread throughout. One is that it definitely points to our need for being in sessions like this, where we're talking about the experiences of our young people and ways in which we can offer them support. What I like about this video is that, and it's from the CDC, and you all will get links to all of the material that I'll show today in case you want to dive more, because as you saw it sort of alluded to, there's module 2 and module 3. And so there's quite a few modules posted on the CDC's website surrounding ACEs. But what I like about this video is that there was a thread of hope. There was a thread that with proper support, with a collaborative approach, that there's hope for our young people, that they can recover from what has happened to them, and they can move on and transition to adulthood and make some significant impacts in our world and in our communities. And I think that's the hope that I know I hold on to during the work that I do. And I hope that you all hold on to that same hope, that with the work that we do, with us asking questions, with us offering appropriate referrals to families, that our children can make sense of what has happened to them. And as the video talked about, parents can make sense of what has happened to them as well, because sometimes it's generational. They can make sense, progress, move on, and contribute to their family, contribute to their communities in a healthy way. And so again, that's there's a lot of videos that center around ACEs, but this is just one that I like to hold on to, because I like to be able to offer hope to the clients that I'm talking to. And of course, hope and recovery looks different depending on what someone has experienced. There is time frames around all of this, but sometimes you'll know that some families in our communities may not even think past what has taken place. And so us being professionals, pausing, letting them share their story, and then connecting them to the needed resources can make just a world of difference in their life. And that's the hope that I hold on to. Not that it'll happen or change right away, but the idea that there is folks out there that can offer them support, help them make sense, and be able to progress on. And so this is just a depiction, which I won't spend a lot of time on. It'll be in our resources, but just talks about all of the different adverse experiences and how they could, the research tells us everyone has experienced at least one, but 4 or more, we need to become concerned. And really the idea is this early intervention. And that's where you and I play a huge role, because we can connect folks to resources early on, especially when someone discloses to us, or they say key things that make us curious that perhaps something has taken place that we need to be concerned about. And so I see our time is I want to make sure I get to the actual therapeutic approaches and things that you all can do as medical professionals. So just a reminder, we all experience life the way we experience it, and there isn't really no set trauma responses. Through research and through practice experience, we know that certain things show up, but there's no set way in which someone responds to something that has happened. We know that their response is related to their coping mechanism, or what I described earlier, their need for survival and safety. So this is just a list, but it does not capture all of the type of symptoms that someone may experience, because we know that we're still learning about the brain. We're learning about how people see the world and how their coping mechanisms may show up to keep them safe. And again, culture, developmental levels all play a role in some of the symptoms that we may see a client may be experiencing. So in research, it talks a lot about the 4 types of trauma responses: the fight, flight, freeze, or fawn responses, or some people like to call it the 4 F's of trauma. Now, the fight or flight response, we know it shows up from head to toe. And I actually like to talk to parents like this. the child's response or their hypervigilant state may show up from head to toe. So they may see their child having rapid heartbeat. The child may complain about a lot of stomach aches or having to run to the restroom or not running to the restroom at all. So helping parents understand that this response can happen in any parts of their body. And so just be mindful of what is taking place. Now, I pulled out the fawning response because I think that one is often overlooked. I think it's often overlooked because a lot of time, I see someone put bedwetting for sure. A lot of times with the fawning response, and let me say it like this, we are more accepting of behaviors that are pleasing, what we perceive as pleasing. So when the fawning response as it relates to trauma show up, it may be overlooked. So this idea of people pleasing may be overlooked because they're like, hey, they are doing the things I need them to do. They're going and getting things for the family. They're never saying no to things. So sometimes the fawning response can be overlooked because it's a pleasing behavior. But when I talk to clinicians in my class or future clinicians, when I'm teaching social work, I always say, you be curious about everything. Even those responses that may seem a little bit less threatening or perceived to be less threatening or seem to be not as obvious. So you be curious about everything. It's better to ask those questions, state what you noticed, and then especially depending on their developmental level, being able to let them describe why they do those things. And you'll be surprised, I've had clients that I'll say, I noticed that you tend to try to please all of your friends at school, regardless of how they treat you. This is a young person who came to me because of really severe bullying, but they didn't really see it like that. The parents saw it as something to be concerned about. But in talking with the child and giving the child space to tell their story, they talked about wanting to please every single child in the class, spent time looking over their shoulder, making sure that the other students in their class was okay, going above and beyond for actually young children that was being very cruel to that person. And then, later unpacking, taking my time in the treatment, finding out that actually this need to please came from something that was taking place in the child's second parent's home. So again, just being curious about even those responses that may seem like, okay, they progressing, they moving along. Even being curious about when a parent says, yeah, they were really down and this is more on my mental health side, but it plays a role here. And then there's a change, but there's a positive change. And so that, goes into a presentation about, being able to be curious about even when there's a change in behavior that's positive, especially when we're talking about someone who may be experiencing some really severe mental health concerns. That change could be actually them settling with dying by suicide, for example. So again, just being curious about even those behaviors that we don't typically think about when we are assessing for what has happened to a young person. And even for adolescents, which is mainly the population that my cutoff in terms of who I work with, adolescents is my minimum age, and then we move on up to adults. But just being mindful that adolescents, they probably even more than school-age children express deep feelings of fear, shame, and even isolation because of what has happened to them. You may even see some of that aggressive behavior that parents often associate with something else instead of being curious about, has something occur in my young person's life that I need to be should be intervening or connecting them to appropriate support. So in terms of what I want to leave you in terms of the signs and symptoms is to trust your insight in the reactions that you see with your patients. Has there been a change in their personality? Has the parents disclosed the change in their personality? Has the parent talked about memory loss or any behaviors that are not classified in the age range as the young person? Are there any self-harm symptoms that are disclosed by the child, by the parent, or you notice yourself? So just being curious, asking questions, looking for any changes or signs that something has occurred. Also, depending on where your young person is located, there could be something on the news that you're fully aware of that happened in the young person's environment. So you may want to be curious and ask questions and check in with the young person. My quick example of that, I just had a recent client, teenager, and I don't watch the news a lot, but some kind of way I came across that in one of the middle schools there, a parent died by suicide at the school. So came to the school building, came to the office, and decided to die, and ended up dying by suicide in the office. And so my client, knowing that the client is from the same city as what has taken place in actually the same school, there could be some reactions there. And it's interesting, the client sort of talked about, oh, that didn't mean anything. That wasn't that wasn't a lower grade than I was in. You know, they kind of started off like that. That wasn't a lower grade than I was in. I'm just mad that we didn't get a chance to do, you can fill in the blank. I was like, okay, I'm just checking in. Next session, the client talked about, I said, yeah, so, you know, did they ever finish, or like what happened at the school? You know, was there any sort of follow-up for you all? And then the client started talking about experiences that they had themselves as it relates to what had taken place. Now, keep in mind, this was like 2 weeks after what I knew had happened in that city in Ohio. And so the client talked about being overly concerned about their friends and how their friends were feeling, and they called their friends over and over again. They were really concerned about their friends' well-being. And so again, on the surface, they may be like, oh wow, that is so nice of you. But diving more into that was their way of coping with what had taken place. They became overly concerned, not really about themselves, but all of their friends, to the point where it was sort of obsessive. They were calling and checking and texting their friends and trying to make sure they were okay. And what I did was I gave her a space to be able to, later down the line, diving into it, gave her a space to talk about how she wasn't okay. And so here's just, and again, you all will get these slides. These are some of the things that I talk to when I do parent groups in terms of what actually are protective factors for someone who have experienced a traumatic event. Defining protective factors are those things that may decrease the likelihood of the young person maybe developing some of those severe reactions to what has taken place. And it starts with healthy practices, but then it ends with feeling close to at least one adult. And going back to my spiel about how I like to be able to offer hope in a broader sense, being able to really dive into this idea that one of the greatest protective factors is when a young person feels close to at least one adult. So helping them understand that they can be that one adult, given context of what has taken place. They can be that one adult that the child can go to get the support they need, whether it's trusting you to listen to their story, or you connecting them or the family to needed resources. So really empowering the family to understand that feeling close to at least one adult is really the greatest things that we can offer our child when they have experienced a traumatic event. And then helping them to identify, if it's not them, who can they turn to? So in terms of some of the trauma-informed care, there's a lot of information on SAMHSA's website that talks about what does trauma-informed care looks like. And I want to pause and really highlight that there's a difference between trauma-informed care, which I think we all should be mindful of, because it's really a process that requires an organizational response. So even the folks at the front desk, how they interact with the young person when they enter the building, how they are treated in terms of being able to call their name, pronounce their name, all of those things, really a trauma-informed care is an approach that we all take together. Trauma therapies really require specialized training and support. And so this may be familiar with you in terms of the 5 guiding principles of trauma-informed care. This idea that you make sure that you're ensuring safety, choice, so giving them ability to choose between two appropriate responses. Because as we talked about, the lack of safety, what the person feels, giving them choice helps them gain some control over what is taking place. And then collaboration, trustworthiness, and empowerment. And you can, of course, go to SAMHSA's website to dive much more into these 5 principles. So I want to talk about, in terms of trauma-informed therapy or trauma-informed support, so being able to identify intake screenings and assessments that will be appropriate. And I actually also included a little script that if someone in your practice may, like, well, how do you start this conversation about, I know something has taken place, but how do I even start the conversation with the parent or the young person? So I just provided a little script, and it starts off, it is common for people to have experienced stressful and upsetting events, even if those events happened to you a long time ago. Those events can still affect how a person thinks and feels today. Things that happen to us affect us in how we react to other people and situations, even many years later. And so you can see how it sort of goes more into helping them understand what trauma is. And then you can present the intake, you can present the assessment. And so letting them know that I'd like to understand your experiences more and answer any questions that you may have, or things that may come up as you complete the assessment. And then I want to show you one of the assessments that we all like to, we tend to go to in our practice when we were assessing for child and adolescent trauma. And it's called CATS. And it's widely used. Even parents can be involved in this questionnaire because we can get some of their feedback during the process as well. So if you're unsure about an assessment or screening, this is a great one. It's been validated and used a lot in practice. And of course, when we are inviting our young person or the family to complete the assessment, letting them know they don't have to disclose what they don't want to disclose. maybe it's not the right time for them to talk about what has taken place, just let them know we can circle back to this when they're ready and when they're able to talk about it. So we often follow our clients' lead in terms of when they're ready to disclose. But sometimes when clients take the paper and they fold it up and they put it in their purse, you never know what that impact does for them, because they may later look at it and say, and follow back up with you probably at another visit. Or maybe not follow up with you, but follow up with the school social worker, or follow up with the counselor at their school. So in terms of effective treatment, I'm not going to show this video, but trauma-informed CBT has a lot of empirical evidence used in supporting young people who have experienced a traumatic event. Actually, it was originally developed for children, but is often used with adults as well. So if you're just curious about trauma-informed cognitive behavioral therapy, you'll have this link for a video that will show you what trauma-informed CBT looks like. So then when you're educating your clients about what to look for if they're looking for a therapist, encouraging them that, I heard that clients that are trained in cognitive behavioral CBT often have the resources that can support your young person. Eye movement desensitization and reprocessing is also another form of therapy that's used for someone who has experienced a traumatic event. And I'll have the video to that as well if you're curious about that sort of therapy to support a young person. And there is talk that rapid eye movement desensitization also helps children as well. I know it's done a lot with adults, but there's some work around how it supports a young person as well. And then exposure therapy, again, when the client feels safe, exposure therapy, helping them get reintroduced to some of the things that they may be avoiding because of what has taken place. And usually this is a gradual process that a therapist uses to be able to gradual approach that the therapist uses to really support the young person and help them get back to their level of functioning that can help them experience life in a more healthier way. So exposure therapy and trauma has also been seen to be effective as well. And of course, we have medication. And then my last, which I'm not overlooking that, I'm just recognizing that the time is coming to an end. But also some other interventions, psychoeducation. So hopefully that's conveyed that I believe it's important for us to educate our clients on what they could be experiencing, how is it showing up in their clients, in their loved one's life, and then connecting them to support. Relaxation techniques. I think there's nothing wrong with doing this. Maybe if you notice the client comes to your office, they're hypervigilant, they're in distress, taking a moment to pause and leading them through maybe a breathing exercise. Really doing this right in the office can make a big difference as well. So encouraging you to consider that. Effective monitoring, and I have links for all of these that you will get, helping them, so the metacognition, helping them learn about learning, especially when their learning in their school is impacted, coping skills, so always asking, what has helped you in the past? And if they can't articulate it, being able to give them resources. There's lots of resources on things that folks can do to help them really recenter themselves and help cope with some of those intense emotions. We talked about exposure therapy. We did not talk about narrative work, but I think I've sort of discuss that throughout our time. And that's really just to give folks a space to tell their story. And then strength-based therapy is also important because a lot of times when something has happened to you, your brain starts to focus on the negative. So you being able to give them or highlight their strengths, highlight that, wow, that was really tough that happened to you. But then being able to center or reframe the conversation or shift the conversation is more appropriate to some of their strengths, and helping them identify some of their strengths can also be very important when we're creating a trauma-informed approach and intervention to care to, again, helping educate and helping respond in the hopes that we're creating a safe place where our young people can know where to go to heal and find resources and find support. So I'm going to stop sharing my screen here.
Thank you, Dr. Johns. That was excellent and very informative. Do we have any questions from our audience? I do have a quick question, and that's related to timing of the trauma. And do you see, and maybe, I'm not sure because I got a little bit from what you were saying, but do you see differences in reactions based on the timing of the trauma of the patients that you see?
Oh, yes. And when it's something that's happened right away, we want to discuss crisis intervention. So sometimes the approach we will actually dive into addressing the what has happened right away and being able to do some crisis intervention work. And the School of Social Work, we actually just got a major grant to teach folks how to do crisis intervention work, because sometimes this response and what the young person is experiencing needs to be addressed right away. But again, the response and how it shows up can be very vast. And we know that when our young person experiences something that is their story, they own it, and we, regardless of if it was 3 years ago, we still want to be able to offer that young person support.
Great, thank you. Thank you very much.
Mhm.
Any other questions from the audience?
If I might just ask a question. When I was a medical student, I had to do an essay about early childhood development and things that were maybe dilatory. And what I did was the work of Bowlby. I don't know if it's still extant, but Bowlby showed that the first 6 months of the development of the child is very, very important, and maternal deprivation causes some very bad things to happen. So I was wondering if you could comment about it. Also, I did ask make a suggestion. Children under bombardment, like happened in the Second World War, in London, others today who experience the same type of bombardment. These young children actually have a lot of problems with things like nocturnal enuresis, bedwetting. I wonder if you could just comment on those important features.
Oh, sure. Yeah. And I'm so glad you highlighted it. It's so funny when we do these trainings, it's never enough time to really go into a lot of the things that, as you can see, this is something very close to my heart. So being able to dive into all the nuances we could not get to today. But the first 6 months, absolutely. Now, again, a lot of my work focuses on adolescents and young adults, but the way in which the young person experiences life in those early stages has a huge impact on how they see the world. But the good news is that, and I think the ACEs study alluded to it, is that the young person, even if they had a rough start, they can create new neurons and make sense of the world. and show up in a way that is different than perhaps how their life and those key factors that may have been disrupted as a young person, as an infant, I'm sorry. So a lot of work is done in that area. And like I said, and with the other work that you mentioned, so much more for us to learn, and only an hour for us to really dive into it. But thank you for highlighting that. And I do see your comment, Dina, and I thank you for the work that you do around human trafficking, because that is also a major concern for our young people, and can be is very traumatic, and that's actually something that we could have dived in as well. But I just want to acknowledge the work that you do in that area. Any other comments or questions for me?
I had a question and a comment. Hi, I work with adolescents primarily, and I really enjoyed your talk. It's very informative. We're seeing so many young people now with mental upset, some of them with real mental diagnosis. Is there anything that, not that I'm saying the schools, this should be their primary job, but kids spend so much of their day in the school setting. Are schools overall doing anything in terms of like adding relaxation into the curriculum, coping strategies, meditation? I mean, being more actively involved in trying to assure kids, that they can focus on their strengths to make school a more calming place, because we've seen a lot of violence in schools, but kids spend so much of their day in the school setting. Not that you want to add something else to the school, but if there could just be something in the curriculum. I was just wondering, are any schools trying something like this?
So a couple of things. I'm so glad you brought that up, because a lot of this work can be done in the schools, but also acknowledging that our teachers are already so overstretched or very stretched in terms of standards that they have to meet in things of that nature. I'll share that I do some trainings with parents directly inside the school. And I want to say it had to be before the pandemic. So it was probably 2019. I walked into a DPS CD school. I think I got there a little bit early, making sure I knew where to go. And on the PA, the principal or someone in the office was leading the kids through a mindfulness exercise. This was the start of the day. And boy, that really just made the biggest smile on my face. The reason for that is because we don't know what took place what took place for the child as they made their way to school. And I think the principal or the school was cognitive of that. So being able to start off with something relaxing, a mindfulness technique, I think that was the best. I was like, wow, all schools should be doing this, like really helping the child. Okay, you woke up late, so-and-so was arguing, this and that, and now you're here. So let's take a moment, let's relax, let's do some deep breathing, let's do some mindfulness things to really shift your brain to now it's time to do the work. So that was one of the, I immediately thought of that when you were talking, Sharon, because I was like, what a great thing that one school, I don't know if all the schools were doing it, but that one school did. And I thought that was just the most beautifulest thing, because again, we don't know what it took for the child to get to the school. I also want to say, I know there's been some state funding around group therapy for depression and anxiety that has been taking place. I'm not sure if all the schools have gotten the training, but it's called Trails for Wellness, I believe. And they offer a 10-week session that helps children understand how depression shows up, what it looks like, and also with anxiety, and then give them ways in which they can practice coping skills, understand what coping skills are, understand emotions. So I really like that curriculum, and I believe DPSCD has it. I'm not sure if all the schools implement it, because there's like a big training that happens first, but then the person who gets trained is in the schools offering kids an understanding of what is this and how does it show up. But again, shifting to the good news, these are some things that you can do to help you recover. So I do know a couple of things are happening, and I can probably go on and on, because I did hear a podcast that I thought this was great, and I actually saw it in my son's life as well. Schools that were starting off their like first hour with gym, because we know that any sort of behavioral activation, any sort of movement can have the greatest impact on all of our health, being active and movement. And it was a study that was looking at how having every child start off with gym for their first period, and how that changed the environment of the school. Kids were a little bit more calmer, they were able to focus. And I just thought that was really great. So and saying that about my son, he had gym the first period when he started high school, and I was really excited about that. He might not have been, because he didn't see the big picture, but I was like, yes. So start you off with some movement, some releasing of some of that, and and that can help you move about your day. So I'm a big advocate for that as well, but I'm not sure how many schools are able to have the ability to offer gym to every student as a first hour course.
Thank you.
Mm-hmm. I'll put the link to the Trails for Wellness information in my resources, because they have an open website, so you all can even print off like things and just have them in your practice, like what is depression and what is coping skills and what are emotions and how are they helpful to you and when to respond when they're not helpful. So they have a lot of resources, and I want to put that link in our information so that you all can be able to have that as well. Oh, somebody said they use those in Wayne Pediatrics. Excellent.
Thank you very much, Dr. Johns. We really appreciate the information you provided to us today. We are a bit over time, so I'm going to go ahead and conclude the session. But yeah, those resources, if you could send out to our team, that would be excellent. And we will probably have you back. Thank you so much.
Thank you, and enjoy your Wednesday, everyone.